physically.
That's
all right.
Make sure of it.
The machine is always listening. So I feel it's important to pay respect to traditional owners. In the case of the land that we're standing on today, it is the traditional lands of the Lenni Lenape. And I would like to pay respects to elders past and present, and also any Indigenous First Nations people who may be present in the room or listening to this or a recording. So to begin with, just briefly to illustrate FAIR, and FAIR standing for findable, accessible, interoperable, reusable. You're going to get some great illustrations of FAIR in practice, but I thought just to start us off, really broadly speaking, FAIR is about focusing on making the data accessible and actionable via machine. And a real incentive for doing that back in 2016 was because there's the growing recognition that there's more information and more data than we can handle individually. So we need to find ways to have the machines work effectively to help us. And also in terms of just the productivity and the usability and utility of information and data, the more accessible it is and the more findable, the more you're likely to be able to start building new rather than existing. What you'll see in the principles is that really what we're after is an effort to create data about the data. So there's often a concern in terms of FAIR initially that people think that this is a grab for data to be able to get access to data or to make the data open. And that's not, they're not the same thing. They're not interchangeable. Of course, you can have open data that is FAIR, but it's really about ensuring that the access rights are very clearly articulated and identifiable to make sure that all the policies around authorization and authentication are consistent. So it's like finding a way to make sure that it speaks the language of the machine in a way that's consistent in a number of different contexts. So that's the findable and accessible. Then the interoperable and reusable are really starting to hit at that ultimate goal of FAIR, which is about ultimate, optimizing data reuse. And again, you'll see that so much of what we're talking about is adapting metadata principles for both the way that the data is stored and managed, but also the vocabularies that are used to find this data. And so working towards replication. So that's FAIR. There's lots of really nice case studies around. I quite like this visual showing FAIR in the context of a particular paper from a health context. This is making radiotherapy more efficient with FAIR data. And if you go to that, it's publicly available. You'll see the authors take you through how they adopted FAIR in practice. And in this instance, you'll see that they were very much about trying to find protocols that would allow for authentication. There was also both private and public access that was discussed. So again, it's never an either or, it can be an and finding ways to store both the data and the metadata in a trusted facility. So I think it's a really nice way of starting to appreciate that FAIR is offering guidance for good practice that most researchers would be seeking to follow in the first instance anyway. This is just about finding a way to connect it to a universal standard. So CARE adds to that now, because the CARE principles are really where FAIR was focusing on data or is focusing on data. CARE is people and purpose driven. CARE principles come from the Indigenous technology, the Indigenous data community, recognizing an ongoing challenge that has been present for some time, where data has been so often taken from Indigenous communities without authority, without a consent, and claims are being made, again, without returning to the community to ask for insight that might actually show a different story. So I find this very inspiring, and even I would argue that even if you're not working necessarily with Indigenous data, these principles seem a very good baseline to follow. Now, I trained as an ethnographer, and so much of what I see in CARE resonates with the way that I was taught to do respectful ethnography for the same reason. You're taking data that is said to represent a group of people. If you're going to make claims about those people, surely it seems essential to go back to that reference group to ensure that what you are saying is consistent. It's also because context is so rich and so necessary to carry with data as we move forward. So I want to take the last few minutes. I do get passionate and get carried away, so I just want to take a few minutes and allow the rest of the team to speak. I want to make a case for why this is important as a baseline for data, full stop. And in the first instance, it's because as good as our data systems can be for allowing access to the data that we have, I think it's fundamentally important that we appreciate that not everything can end up in the machine. So FAIR is working to ensure that the data that is available is consistently organized and accessible through that. But I've always loved this statement from 1963, William Bruce Cameron. So this is pre-computation, the way that we appreciate it. And it's certainly not the first time it's said, but not everything that should count is countable. It would be nice if all the data that sociologists require could be enumerated, then run through an IBM machine. I'm not sure students nowadays even remember IBM, but in our day that was important. And draw charts. However, not everything that can be counted counts, and not everything that counts can be counted. That is a really important fundamental premise to keep in mind for this, and why I think CARE resonated for me. I think another aspect that's really important to remember is that the data is often representing human activity, even if it's not data directly about a person or a group. It represents the life of society, and behind every data point is a human being. That being said, recognizing that data has an origin well before it ends up in a spreadsheet changes the way that we think about the power of what we're doing with that data. What happens in the process of generating that data can actually potentially contribute to inequity and bias, or increasing inequity and bias, often unintentionally. It's not, you don't have to be deliberately seeking to do that for it to happen. So a lot of what we do, and Anna and I have worked on workshops in this regard, is about making the invisible visible, seeking to find ways to help raise awareness to who or what is missing, misrepresented, or underrepresented in data. And I've always loved this quote, the idea that raw data is an oxymoron and a bad idea, because data must be cooked with care. And I'll talk a little more about careful cooking of data tomorrow in my talk. So I think if we recognize the politics and the power of the vocabularies and the ontologies we're using, it invites us to think about these questions. So I just really put these there as a prompt now and later, thinking about the impact of our worldview and our assumptions on the way that we are structuring and engaging with data, the ways that we are naming things, thinking about what might be made visible at the expense of other things that become invisible. And so the CARE principles to me become that really essential connector to FAIR and keep them human and give us this guidance to look at. What it also flags is that what we're talking about is seeking to not only structure data, but to build better relations with people, and the people who are working with data, as well as the people who are represented in the data. And so that means that what we're talking about is not just technologies, we're talking about putting principles into practice that involve engaging with people, not just the people in the data set, but the people who work on this as well. And so finally, what I want to do is go back to that acknowledgement of country and offer some guidance that I feel very grateful to have received from Indigenous technologists that I've been associated with in some of my work, who've helped me to recognize a different way of trying to address these problems, not necessarily by finding the answer, but finding ways to move forward. So this wheel on the left, as you're looking, that talks about respect, engagement, sharing, and moving forward, was a product of some work that was done at my former university, working with Indigenous students and Indigenous staff to try to understand how to bring Indigenous insight into the graduate attributes within the Faculty of Health. And that mantra of respect is very much what an acknowledgement of country is. It's how do I pay respect to show I'm coming into your space? I acknowledge that, I pay respect to that. To then engage, to find ways to listen and hear from one another, and then to find a way to move forward, not to solve the full problem, but to move forward. And you see that represented in this artwork here that comes from the 1990s, but is representing 40,000 years of connection and storying and moving forward, one country, one nation to another, of all the Indigenous nations within the land of Australia. And what I've always liked about this is this artwork just represents those personal connections. But if you look, it is the same as the geographic mapping of Australia. So one connection at a time, you get the satellite view. So to close, I'll just say, I think moving forward and learning together is a way to apply fair and care. And I just thought I'd put these questions there to think about the different ways that each of us individually could think about vulnerability and who the vulnerable citizens in our charge are, or in the work that we have been doing as researchers or as data stewards, thinking about what concerns are invisible and need to be made visible, and how to remain alert to the missing, misrepresented, and underrepresented. So I thank you for the opportunity to start off the conversation here. And if you did have any questions, I'm happy to take them later on via email if we run out of time.
Thank you. Thank you, Theresa, for this introduction. So reminder, if you have any questions, please save them for the end. You can start typing them on the Q&A section. So now we'll have the three presentations focusing on data sharing efforts, which is more on the first side of things. So I believe the first one is you, Ron. Yeah. I'm gonna just simplify this. Sharing screen. Hiding this. That you have. I just click. Yep, or just the arrows.
Okay. Hi, everyone. My name is Ran. I work at the UHC, and today I'll be talking a little bit about kind of a case study for FAIR, especially within the Solar Ball project in a collaboration with the World Fair Organization. So implementations and lessons being used. So just an overview, we'll talk a little bit about FAIR and Solar Ball, the story, our implementation plan, sorry for the typo, but really wrap up with summarizing the collaboration that we had with World Fair. So just some context, I think this is very familiar to everybody, but Solar Ball is a multinational data harmonization effort. And the idea is to enable cross-country analysis of data. It's funded by the Wellcome Trust, and we started this whole journey because we were wrapping up the project and there was a mandate to share our data. And now the question was how. And the thing with Solar Ball is each data set is harmonized from many different data sources across countries. And this harmonization process is what makes the data so valuable, but at the same time is what makes the stewardship and tracking of the metadata very, very different. So this schematic kind of briefly summarizes the Solar Ball process. So for example, we have some raw data from various countries, Brazil, Mexico, Chile, Peru. And we do this harmonization, so we standardize them into similar formats that we can do analysis. But really the challenges of Solar Ball was this was happening across countries, across data sources, and different teams, so spanning country, teams, and also domains. So it was very hard to manage. And some of the challenges we faced were just the volume of data, the fact that data sets were composed of other data sets, and we needed to keep track of the metadata really at a data point level. And then, yeah, and that each data source and harmonized measure has different metadata at the data point level. And so just, I won't talk about the technical implementation, but just a brief schematic of how we approach this problem was to take those individually harmonized data sets and then to kind of develop a metadata and data standard, and then to standardize each of the harmonized data sets into this project-wide standard, compile them, and then create an interface to allow for both public users, mainly public users, to come and access our data. And the end product of that interface, we liked Amazon. So we built kind of like a shopping cart where you can go in, browse our data at the measure level, and view it much like Amazon, where each item is a measure or a variable. And then add that to your cart, and then we have an automated process that combines stuff, creates a code book, and just sends it to you. So it was a lot of fun to build. And so now I really want to shift a little conversations and talk about our collaborations with World Fair. The World Fair is an organization whose goal is to promote fair practices. And fair practice, and one of the things that we've learned is in the beginning, I thought they were going to solve all my problems. But the fact is, fair at the state of it right now, and Theresa maybe care is different, but it is a set of best practices. It is not an implementation plan. And so what you have is you have organizations with different needs, but you do want to build these best practices. And World Fair acknowledges this, and their goal is to try to start a conversation. And so one of the ways of starting the conversation is data gathering. How are different organizations across domains implementing FAIR? And so, by luck or whatever, SolarBall was actually selected to represent the urban health domain, among many other domains. So we're working with biologists, chemists, astronomists. It's a very interesting collaboration. And so we produced a few deliverables. One was just that plan. How do we move SolarBall towards a more fair state? Develop some trainings and also to develop reporting of what we've done after the fact. And so that's a rough summarization about where we're there, but just a few lessons that we learned along the way is that our problems are not unique. I think both from the fair side as well as the care side. I think there are many organizations facing the same problems, and embracing these well-established frameworks and networks and communities who are thinking critically about these things is a very good thing. It helps you exchange ideas, to find alignment, seeing that we're struggling with the same things, what are other people's solutions, and just learning about that. And also for us, it was extremely valuable just to talk with outside experts and get validation on our strategy, and also to get feedback on our strategy. And also to bring all this back to our own research projects. And how am I doing on time? Okay, so I think there was a few things that kept running around in my mind after I wrote these slides, but just to review, I think FAIR at the state of it right now are a set of best principles and not an implementation plan. And this World Fair organization, and I think this idea of starting conversations and talking about how various projects are implementing FAIR to identify convergences is a good first step towards moving towards concrete, actionable implementation plans. And then lastly, it was very interesting to collaborate with all of these organizations within the World Fair. And one of the key things that, at least for me, I feel like what is effective collaboration was in the beginning, people were kind of scared. It's like, oh my God, I'm going to fill this form out and say what I did, and other people are going to judge me. I'm like, oh my God, my project is not doing so well. But I think it's very important to understand that, at least within that community, I think it was the people who led that project were very responsible in the sense that, this is a conversation, this is not a score. And having that mentality and not bureaucratizing implementation at the project level was incredibly helpful for us to have effective conversations. So with that, yeah, thanks. And if you have any questions, happy to chat.
Thank you, Robert. So next will be Matt. Bring up the slide.
Thank you, Osama. All right, yeah, so like Osama introduced me, I'm Matt Jannetti. I work on the back end and all of the front end stuff for the UHC data portal. I'm going to be talking to you a little bit today about what it is, what's on it, and how we are using it to help us, implement or use FAIR principles at the UHC. All right, so first thing, what's on the data portal and what is it? So it is a website where UHC or School of Public Health affiliated faculty, staff, and students can access data sets that are created right here at the UHC. So things that we've collected and compiled and merged and put together, and we put it all up so you can access it. Currently, there are 52 data sets available. And we also post little things like monthly blog posts or resource sheets to help analysts like understand and use the data. If you would like to take a look at it, it is URLs right down there. It's data.uhcdata.org. All right. So just to take a little bit about what it is that we're doing, this is kind of like a little bit of an intersection between FAIR and open data and not quite so open data stuff. We are using an open data framework to help us build this portal. It's called CCAN. It is used by a lot of different places across globally, but in Pennsylvania, it's used by Open Data Philly and the Western PA Regional Data Center out in Pittsburgh. And what that means is that actually, like if you've used any of those sites, you kind of know how to use ours, which is really convenient. But it's also very customizable. Like we can make it look like a UHC data page. We can add functionality, like the ability to export out like RAS files so that people can just take it and import it into their own little like citation management software. And so it's a lot of things that we can do with it that makes it really work for us. But it is also helping us implement, you know, some of the principles of FAIR in our work. So the data portal, to me, mostly helps with findability and accessibility, right? What it is it lets us collect a bunch of metadata, store it all in a single place that is, you know, related to the data set, so you can see it all, and you can look for it, and you can search. You can use the web interface to search for it, and you can also access it via API, search for it, and pull it in machine-readable formats. So let's talk a little bit about the metadata and how it exists on the data portal. So every data portal has a bunch of data, has a bunch of metadata uploaded. So this is things like code books and data dictionaries that are, you know, uploaded, and the links are right next to where the data actually is. But also, you know, we can upload a bunch of other stuff. We customized it to add a bunch of data that is not usually there. So things like, you know, when the last time it was updated, who's maintaining it, what the source is, the date range of the data, what geographic extent it covers, things like that. And that's, again, all available like right there on the website. But also, it allows us to have a searchable database as well. So if you upload, as when we upload like a data resource. So one of the first things it helps us do is it actually helps us organize the data into groups and domains. So we can take things like demographics or health outcomes, and you can click that, and it will bring you all of the data that we have on health outcomes that's currently up on the data portal, and you can browse it, and you can find the one that you want. Each data set, you can also get more specific. So each data set can be used with specific filters to like that are tags to use for things like geographic area, like Philadelphia, or topic like climate for things like climate change or weather data. And data can be filtered by other things such as format, including, you know, is this a text file, is this a SAS file? If you want to find all of the spatial data files, I know Steve likes this a lot, you can just see like, yeah, what are all the spatial data sets we have actually on there? And finally, like the search lets you search through all of these different things via keyword to find the data that you're looking for. So as far as what it kind of looks like, you know, you can kind of see over here that we have like the groups and the tags, and you can click one or more of those options to narrow down exactly what data you want. And we provide just like a short title or description, so this way you can understand what the data is at a glance, as well as what formats are available for it right underneath. Okay, and now let's move on to accessibility. So when we upload a data resource, as long as that data resource is readable by CCAN, this is usually like some form of text file or JSON file or something along those lines. it automatically gets uploaded to a database that is searchable and accessible for APIs. Like we don't have to do any other work other than just uploading it, which is great. Also, as a plug, API access can be given by request. If you have access to the portal, please email us at uhcdata@drexel.edu. And each data set has a resource ID that connects everything, all of the metadata, everything that you need to know. And that also can be used to find that data using the API. So each resource that is available on the API has, on the top right, has that little green button. Down there it says Data API, and you click it, and it opens up a little like light box for you that says, "Cool, this is how you actually query it." So you can copy that URL into your thing. You can modify it. You can change it using the CCAN API documentation to get what you want, but it will get you to the data that you need. If you also like open up these boxes down here, it'll give you some example code in Python and JavaScript for you to be able to even just write your own custom code to access it. So makes it like the CCAN template makes this all very, very, I think, user friendly for at least people who know how to do API calls. But that's the data portal. I focused the conversation on that, but I want to also broaden it a little bit right now, because this is not all we are doing at the Research and Data Core. One of the other big projects that we have coming up, and we have been working on for a while, is a metadata database of all data at the UHC, including ones that aren't on the portal, right? Because we can't put everything up on the portal, right? Some stuff has restrictions or DUAs or whatever, and we can't put it up. And also it takes a while for us to process all of that. So it'll help us to bring FAIR principles to non-portal data. We are creating a database that will contain information about variables and data sets and measures and all of the stuff that will be searchable, ideally, for everybody to use at the UHC. Also, we are working on something to help us increase interoperability by setting standards for data going forward at the UHC. So people will, define data in the same way. We'll use the same naming conventions. We'll always store dates in an acceptable ISO format, which would be great. So this way we can all transfer data between projects and reuse and use that data in a much easier way at the UHC. All right, so finally, last bit. You can request access to the data portal if you would like. You can visit us at data.uhcdata.org. We have a link to a form up there that is also in this QR code right here if you want to scan it real quick. And it'll ask you just like a question like, do you work at Drexel? And if the answer is yes, then we'll give you access. And yeah, so if you have any questions, please reach out to the Research and Data Core at uhcdata@drexel.edu. Thank you. Case by case.
Hey, now we'll go with a non-Drexel example, but local here to Philadelphia. So let me pull up your slides, Megan. And Megan, the floor is yours.
So hi everyone, I'm Megan Todd. I am the Chief Epidemiologist at the Health Department here in Philadelphia. And excited to be here. This has already been really fun getting to talk about how we're sharing data and even trade some Australian fashion tips. So that's great. So originally I was going to talk about one of our efforts to share data more broadly. And I will get to that, but I want to set a little bit of a stage for how we're thinking about data sharing in public health practice first. Sharing data is really hard, and there are a bunch of challenges. One is that we're working with legacy systems. They're proprietary, they're using old coding languages, a common story from a health department would be, oh yeah, that's in some access database that, oh yeah, Bob built 15 years ago, and he's the only one who understands it or knows how to use it. And then Bob retires, and we're out of luck. We have paper-based systems that we still use. And I was actually just at a conference last week with a bunch of other health jurisdictions from across the country, and you just hear these stories. So we have all these different systems that don't always talk to each other. So one piece of this is also just the complexity of public health data. Got lots of data, lots of partners. We're sharing data with the CDC, with the state, with laboratories, with hospitals, with primary care physicians, with vital records. And it's lots of different kinds of information. We have case reports, we have immunizations information, we have Medicaid claims, vital statistics from birth and death records. And so a really typical story, which was one of these stories that I heard last week, is that a jurisdiction talked about how for 11 reportable conditions, they had to use 20 different data systems to enact the report and to share with all their partners that they were required to do. And part of this challenge is also that there are different laws and standards associated with different data sources. So there are state and federal laws about how we can share behavioral health and HIV data. There's, oh gosh, I think it's Act 59 in Pennsylvania, which limits how we share HIV information. And so, the different data systems, even within the health system, have to follow different security standards and storage standards. And then another challenge is that we generally take a conservative approach towards sharing. I think, health systems, public health departments are dealing with private health information, identifiable information, and they're shared with us for a very specific purpose, which is to, track reportable conditions, to prevent epidemics. And so there's a lot of hesitation to move beyond that purpose that explicit purpose that they were collected for, even if they might be useful for other things. I think, there are good reasons for this and maybe less good reasons for this conservatism. I think arguably a less good reason is nobody wants to be on the front page of the Inquirer for being the person who led to a data breach or shared some information that shouldn't have been shared. Kind of the better reason for it is I think we take very seriously the importance of public trust in order for public health to be able to do its job. And if folks give us their personal data and then we're sharing it around willy-nilly, that public trust is going to be damaged or can potentially be damaged at least. And something we saw during COVID is that trust is incredibly important when we are facing emergency and really need to get some stuff done. So there's some challenges, but there's also been movements towards more sharing and more fair-like principles. So one thing that happened during COVID is it was a big emergency. Everybody was all hands on deck. We did everything we possibly could. And hey, it turns out when everyone's working nonstop, you can get those data systems to talk to each other, and you can find ways to connect them, and you can move folks off paper and into electronic systems. And so as we come out of the pandemic, there's a lot of discussion kind of at the federal level, state level, local level about, well, how can we learn from that experience and take some of those modernization principles and apply them to our data systems as we have them for other, take those lessons and learn for areas other than COVID. And the CDC currently has this data modernization initiative, huge initiative, $5 billion over 5 years. And that is for building public health infrastructure. And so the key words associated with this grant are kind of all these things that you hear when we talk about FAIR. So it's, it's flexible, it's interoperable, it's scalable, it's open. All those things are things that we're all going for, and we have this very unique infusion of money to try to get there. CDC is also spearheading some efforts to standardize data collection and sharing across the whole country and all the jurisdictions. So they are kind of starting to talk about specific data systems and asking people to, adhere to certain principles to make them interoperable. And they're also developing like a template for a standard data use agreement that can be usable by all. But, you know, of course, this is still really hard. So sustainability, you know, $5 billion, great. I won't say no to that. But what happens in 2027 when that runs out? And so when you're thinking about how you spend that money, you kind of have to be thinking about what are the infrastructure changes that I can make now and that I won't need to pay for later. And what that means is it's not staff, who I think is really who we need. We need that expertise who's going to stay with us and keep that institutional knowledge. So, you know, this boom and bust funding cycle is not going to help us be prepared for the next pandemic. And what happens after 2027 in terms of this funding depends totally on who's president, who's in Congress. So, you know, it feels high stakes. And then also kind of this conservatism that I was talking about, it's still hard to dislodge. So, you know, CDC is kind of trying to make these efforts to standardize and get everybody on the same page. But lots of jurisdictions are skeptical. They've been doing their thing their own way for a long time. Why should they change? You know, the original data use template was written very broadly such that, you know, CDC could basically do anything they wanted with everybody's data, and almost all the jurisdictions were like, not even talking about it. You know, and so this is that human piece, that culture piece that Theresa was talking about, right? Change is hard, and it takes time to convince people that you should be doing it, to prove that it's a good idea, and then to actually get there. Okay, so then back to what I was originally going to talk about, which is Philostats, which is a data portal that my team built, a dashboard for vital statistics reporting. And this was a huge team effort to, so thanks to Anik Shears, who led most of this work, and then the rest of my team members, Shivani Salmian, Giselle Backyards, and Maddie Bowden. And also that little logo in the bottom right, that's our brand new logo that we're just trying out. We used AI to generate it, so. So I don't think I need to convince the folks in this room that vital statistics are important. We're talking about births and deaths, and they're, I would argue, the most important source of health information. They can tell us who's dying from drug overdoses and where they live. They can tell us how many babies were born by C-section and talk about disparities in birth outcomes. And they're really useful for policy and program implementation. So every year we talk with the schools and say, hey, how many babies were born 5 years ago? How many kindergarten slots should we allocate and where? And then thinking about things like gaps in care. So they're great, but they're not accessible. They're really hard to find. Often when you're looking for local vital statistics, you'll find a PDF buried somewhere under the local public health department's webpage. And I say that because that's what we used to have. So this is the 2016 vital statistics report, only available in PDF. So we had, you know, 30 pages of tables like this, which like, I mean, turn on usable data, you need like some good OCR software, because it's not even like well preserved there. So tables upon tables upon tables upon tables. And then some like puzzling visualizations. And like, yeah, I mean, this way, it's like all the things, right? It's like pie charts. People talk about pie charts as like messy tables. This is like a messy table on top of a messy table. We've got the pie charts. And then we also have like our regions labeled over here. And then the pies are different sizes based on population size. So, you know, that's really hard to get any meaningful information out of. Right? Plus the colors are terrible. So some of the things we wanted to change was to get away from these pages and pages of PDF tables and move towards dynamic visualizations. Think about those aesthetics, making things that are readable and understandable. Share our data openly. So everything that goes into our vital statistics report, we now share to Open Data Philly, which is the open data source that Matt was just talking about. We wanted to, another way that I think about accessibility is thinking about premium audiences, and so making sure that you're supporting interpretation in a way that makes sense. And so by that, I mean, we're not just presenting a number, but we're presenting a number and a little bit of interpretation, a little bit of reflection on what it means, and importantly, bringing in that structural and social context that isn't always there. We wanted to make something that's that we can automate and would be easy to update. And since we've been doing this, we've used this as a template for other data products that we put together. So how am I doing on time?
Couple minutes.
Okay, so I would go live to the thing if I could, but I'm just going to show you some screenshots to save time. So this is what some of the things look like. So these are scrollable maps. You can zoom in and out on the particular neighborhood you're interested in. You can see different statistics about the population. This is kind of the subway plot is one of our favorites, which shows leading causes of death over time. And so you see, this is a screenshot, so I can't actually interact with it, but you can click on the years, click on enough the years you want. You can pick a sex, you can pick specific races and ethnicities, age groups, and you can choose a metric. So here we're looking at years of potential life lost. You could also look at just counts of deaths. And so this is, part of that storytelling, right? This is a way to make that point about the really important causes of mortality. So, we're talking about years of potential life lost in Philadelphia. It's drug overdoses. Okay, so here's just a few more examples of how we can display data. So here we're looking at birth rates, and again, you can see it's split up by the age of the birthing person, which you can select on the top. You can select race and ethnicities you'd like to see. Maybe you just want to compare two to each other. You can turn everything else off and just show those, or you want to compare one group to all. You can do that. Pick the years, and then you can pick a bunch of different metrics. So there's birth rates. We could look at infant mortality, maternal mortality, a whole bunch of things that you might be interested in. But the key here is, rather than it being in 1,000 pages of PDFs, you can actually look and interact on one page and make it look exactly how you want. And then there's a little, button up here where you can save it just how you have it. And then here's a little bit of a piece where we're kind of thinking about social determinants of health. And so we kind of explicitly are putting these two maps next to each other, where one side has this health outcome and one side is focusing on a social determinant of health. So here we're looking at mortality and then poverty. And just kind of making it easy to tell this story of like the dark blue is where the dark orange is. Things are related. And then this looks familiar from what we just saw, but this is what our page in Open Data Philly looks like, where you can access all the data that we used. And I'm gonna stop there. We have a QR code for full stats that I can also point you to the URL if you're interested. And then the other piece I wanted to say, just thinking about this like interpretation piece. I think, communication is part of our job as epidemiologists. And I think it's something that we don't often think about as part of our job. And so this piece about interpreting and telling stories has become more important in the work that we're doing. So what I just showed you is a data dashboard. Who's the audience? It's people who want to dig in, who know something about data. It's researchers, it's y'all. But like your average Philadelphian isn't going to want to dig in there and find the story in the data. They're going to want to say, okay, what are the important stories? And so we try to do that in other ways. And so this link is to Health of the City, which is, again, a newly updated report. It used to be a big, long PDF. Now it's a beautiful interactive Cordo document with, again, some like baby interactivity and really a lot of focus on readability, accessibility, thinking about things like screen readers, colors that are good for color blindness, reading level, these kinds of things. So I'm gonna stop there and only went like a little bit over time. Thanks.
For those of you online, I've been pasting the links on the Zoom link, on the Zoom in case you want to check this out. Okay, so next we are shifting gears a little bit, well, not too much, to be honest, in the presentations. And now we'll have more of a conversation of complexities of data and data infrastructure, especially in the first case, working with communities here in Philly. So, Amy, you go next. Either one.
Hey, hi everyone. Nice to be here. I see. Go off screen to get onto the screen.
You can use the arrow.
Okay, so I'm here to talk about the experience that we had making data fair and care principled, available to the communities we're working with through the West Philly Promise Neighborhood Project. And Matt was a big part of this project and still is a big part of this project today. So it moved on the screen, but not on the screen.
Well,
Okay, so for folks who've been part of the UHC for a while, you've definitely heard us talk about the West Philly Promise neighborhood. It was a $30 million grant from the US Department of Education. It was one of Obama's place-based initiatives, and it was co-located with the West Philly Promise Zone, which was a HUD designation. It was a cradle to career, place-based, collective impact, cross-sector, cross-system initiative, whatever adjectives you want to use there. The idea is to support kids and their families by knitting together existing programs and creating new programs where needed. We just finished it up in December 2023. We were funded right after Trump was elected in January 1st, 2017. And we can talk about, you know, sort of some of the sustainability of this work, which is one of the complexities of sharing data with such a large grant. The idea was to be able to co-locate and knit together services in the same geographic footprint that was identified for the Promise Zone designation as being an area that experiences social and health inequities shaped by structural racism and segregation and disinvestment for many generations, but also has the promise of many strong anchor institutions, community-based organizations, and nonprofits, and also all of the eds and meds that surround it, including Drexel. So our focus were for kids and families who live in the Promise neighborhood footprint or attended one of the 7 Promise neighborhood schools, the high school being just right outside of the footprint, which meant that our cohort were all of the residents who live in there and kids who come from every single other neighborhood of Philadelphia, the way Philadelphia's Choice School District context works. And so we had a very difficult both program implementation and data story from the very beginning of this project. We had many partners. This is a collective impact model, if you're familiar with it, with shared agendas and you know, looking for areas of overlap of our existing work for sustainability purposes, and then investing in new and enhancing and scaling programs for the purposes of meeting its 5 grant goals. Not at all ambitious, just to make sure that kids are ready to enter kindergarten, they're proficient in all of their core educational subjects, that high school students graduate with the skills they need to continue their education and achieve their career goals, that children and families thrive in healthy, safe, and stable communities, and that families and communities are actively engaged in student learning. So as a result of this, the multi-site evaluation of all the Promise neighborhoods have to collect 15 different indicators. We map those indicators to a social determinants of health framework. I'll show you that in a moment. But just to say that this means potential lot of information to be collected at the point of service delivery, of program implementation, and of city service provision and utilization that all of these kids and families are going in and out of all the time. But I want to paint it in the context of West Philadelphia. There's a very high mistrust of research in this neighborhood, these neighborhoods that surround us. There's a very high research burden. All those eds and meds that I mentioned, they've been researching them for many, many years, and the community hasn't seen any result of that research. There have been lots of ethical violations that have occurred that are very high in folks' minds. There's a lack of benefits to the community from the research, and in fact, often doing harm. Community members feel like it's extractive. They feel like the giving of gift cards for personal information is taking advantage of them and is coercive. And they just honestly don't see any action or solutions as a result. Also, their lack of inclusion in any research conceptualization, creation of research questions, or the conduct of the research makes them feel like they're not at the table. They feel like, I hear often, if you're not at the table, you're on the menu. And so they feel like they're not at that table when important decisions are being made. They also, to be quite honest, are sick of initiatives like the West Philly Promise neighborhood that come in with this promise of, new things are going to come and extract a lot of data. And then they're exhausted by those, the hope, the cycles of hope and disappointment. And then, in general, they're just disappointed by these large institutions that were not including them in using these data to create programs or services, or to use data from them to prioritize solutions, or to use, or how those data are used to evaluate whether or not those solutions are effective. They feel like they're not a part of that at all. And so, it leads to that trauma that I just mentioned, that all of these efforts are not actually changing anything. So how did we step into this work? Well, it was not easy, and we could probably share over a beer sometime a longer story about how things went, but we decided that we were going to have an evaluation design that was in 4 major buckets. One was the primary data that we had to collect. This is what we had control over. So I'm going to tell you about our efforts in democratizing access to those data. So we had collected at the school and neighborhood levels. And we had to create a longitudinal integrated data system, of which the health department and other city services were partners. We had to create a program tracking system for kids and families who went in and out of our systems. And then we built from the very beginning a system and a plan for data dissemination, communication, and democratized access. I'm going to talk more about those two, number 1 and number 4. So again, we mapped the GPRA's Government Performance Reporting Act indicators that all promised neighborhoods needed to collect. We mapped it to a social determinants of health framework so we could fit it in with all of the other data that we collected that we knew was going to be important for community users of data. We were going to change any kind of attitude or culture of being data partners with each other. We were going to have to provide data that was going to be useful for all different kinds of community planning, advocacy, and evaluation efforts. We then employed a model of community-based participatory research where our research team were members of the community. Those research team members went on to take other leadership positions throughout Promise Neighborhood, including a survey coordinator, outreach coordinator, community benefits coordinator. But our design is a longitudinal cohort design. We went to the community from the very beginning, and they said folks are going to want to hear from you multiple times. They don't want to do a cross-sectional snapshot. So we adapted our design to be most responsive to that need. Folks are going to want to tell you whether or not, they want you to be accountable to them about whether a promise neighborhood is fulfilling its promises. So you should come back to the same families. We had sort of eligibility criteria that were, set by the grant, but we included a lot of topics that were hot topics and were really important for community concerns and decision-making. And we did a participatory survey development process where we decided on the domains, and then we matched validated measures to those domains. And then we had community members demo the survey for a good 6 months. So all the flow and all of the wording were tailored to meet their needs. And then we hired and trained and we human subjects certified all members of our team. I just want to point out the fact that in this very high poverty area, which include the projects that folks may know that have since been torn down, that we have very high response rates out in the field, going to randomized addresses, and that we maintained this or even increased it after COVID, which is just unheard of, right? That folks were so familiar with our surveyors, were so familiar with Promise Neighborhood, that they opened the door during and immediately following, well, still, I guess, COVID. So how did we make sure that these data got to more than just the US Department of Education, who, by the way, wanted it in a really not useful format? We did lots of presentations. Anywhere people wanted us to be, we do it. We also did it more virtually, obviously, after COVID. We would do community town hall type settings for these as well. We did a lot of community indicator briefs from the data, the contextual data that we were that we also had control over, as well as survey snapshots. We also sent those survey snapshots back to all of those who were sampled for the survey, both those who took it and those were sampled. We created user-friendly dashboards, both for our community indicators and also for COVID-19 Social Vulnerability Index dashboard that we created as well. We created a community-friendly data code book and provided in-person and online ways for folks to request data from us. And then we hired our surveyors to help us with dissemination, curating data stories from the vast amounts of data that we had. I'm sure you've all seen these. They're up on our UHC website. We're now transferring our Promise Neighborhood dashboard over to UHC for sustainability concerns that you can imagine to sort of maintain this kind of community responsive data infrastructure. You need to have at least a home for it, as well as personnel to keep things up to date. But anyway, just to give a sense of you know, what our snapshots look like, and we had community input and editing of all of our products. Also our dashboards, you guys are very familiar with dashboards, but just to know that we do a lot of explanations of our data sources. And we also demoed these with community groups and have a community feedback form as well. Just want to let you know that this is built on prior models where I've employed, and also orange jackets. I know that's really makes it seem like it's the same folks, but orange stands out when you're in the field and identifies folks. But building on models I've employed in New Haven and in California, but just for you all to know that this model of engaging community leaders, organizations, and actual residents in the planning, the collection, the interpretation, and the dissemination of data is such an important piece of communities feeling like they're taking power back when it comes to research, and such an important part of them trusting those data and using those data, because they are not going to our dashboards unless they understand that they know you and they trust you, or they know the project and they trust the project, or they know, oh, these are the New Haven folks. They know Miss Rita or Miss Christina, so they're going to go to that dashboard. And then I just wanted to tell you about one other effort that I'm deeply involved in. The Promise Zone, because of its designation, folks got priority points on federal grants if they proposed for their grant to take place in that same footprint. That's how we got the Promise Neighborhood grant. What that meant was an already over-researched set of neighborhoods got everyone coming out of the woodworks. And, you know, any IRB can send researchers to a neighborhood. They could be from England, Australia, they could be from Boston, they could be from Pittsburgh, or they could be from anywhere in Philadelphia, and that was happening. And so community members decided they created a nonprofit, now a nonprofit called the Promise Zone Research Connection, or the PZRC. You can find their website here. Back in 2015, and I've been supporting them to create a community research review board, which is now totally functional. You can apply to go propose your research to them, and they'll schedule you at a research review meeting where the community will review your research to ask you questions about how it's going to benefit the community, create jobs, and how it can be disseminated to be of best use to the community. And you can see there's a report of prior cribs here. And we also conducted a study of IRBs in Philadelphia to see how much community engagement infrastructure processes and policies they had. And we're releasing a report, and we have 5 recommendations for local IRBs. It turns out national IRBs are very interested in this, so we've been disseminating this nationally as well, about ways that IRBs can improve their community engaged research infrastructure, could be asking the same kinds of questions of their researchers when they propose research to occur in similar communities of color disenfranchised by research. So that's a snapshot of all the many things that are happening in this area, but a lot of folks made all of this happen, some of whom are in this room. Thanks.
Thank you. Okay, well, last but definitely not least, we have Ortigoza presenting. Okay.
Thank you, Sama. Well, it's hard to be the last one because I have to keep your attention. But I think it's good because I see many connections of what the other presenters did today. Actually, I was curious that one of the cases is on vital statistic because my curiosity on parent care started and my connection with Theresa and this World Fair project was because we were having a struggle on deciding on whether we need to eliminate some maternal age that was below 8 years of age in the process of harmonizing vital statistical or life birth statistical registries. And that's a concern of, well, yeah, it could be an outlier, but it could be a very, very severe case of ethic concerns. So that's how I begin my journey. I'm actually a health equity advisor of an American health organization, but I joined this organization 1 year ago, and most of the work or the proposal work that I would like to pursue for the next years at this organization have been incepted here at Drexel, working with the Salvable Project and many of who are present here. I have to say that my position is also at the, how should I move this? Oh, with this.
The keyboard.
Huh?
With the keyboard.
Okay. My position is at the unit of gender equity, cultural diversity, and human rights. And I think, well, this position has been opened 1 year ago, and I see now the importance of what they are trying to, what they were trying to mandate to my position. The first day I sat down in my desk, there came a lot of people saying, we need disaggregated data. We need disaggregated data. And it seems like that was the main thing to trying to better depict with data the intersection and interaction between inequalities by ethnicity, gender, and other social determinants. As you see here, one of the strategic priorities for the organization to achieve universal health is really accounting for gender inequalities and inequalities or discrimination by ethnicity, because mostly these are considered barriers in access to health, but more broadly, the root of discrimination due to history and colonization in the Americas, and part of what we need to prevent as violations of human rights. And so I started this journey while trying to understand, because I saw that many of the cases were working with secondary data, Amy's working with primary data, but I feel like I'm between, because we need to work with countries to collect the secondary data you're using. And in fact, it's almost the process like collecting primary data for the very beginning. When we start thinking what gender ethnicity data is needed, we'll restrict to these definitions that are so convened by the World Health Organization and the Organization of American States. Mostly relevant to health, this gender identity, sexual orientation, and ethnicity. I'm not going through the definitions because of a matter of time, but I wanted to acknowledge this because this frame and make a context to think about what is the data that we could have and what is the data that is available. This has been a previous work of mapping the sources of data, official sources of data, national level, from country-wise in all countries in the Americas. This has been an effort, not by me, but by other colleagues at the organization. From the last 23 years, they review almost 183 sources of data in these 35 countries, and they try to see, so many of them have many iterations. That's why the sources years is bigger. And as you can see, there is plenty of data, or most of the data that we have is about sex.
but ethnic origin or ethnicity is less frequent, particularly in the Caribbean and Central America. And of course, gender, how operationalized gender is less common. As you see here, the proportion of data available to express or describe dimensions of inequities in health is very restricted when you think about ethnicity and gender. And I think that this idea of thinking of through gender and ethnicity, the challenges of incorporating data is very much tied to challenges of care and care. And what I would like to do with this is trying to, with this presentation, is trying to think how we can operationalize this in terms of processes. As you can see, many of the challenges of the advancement is not only even across countries, but even within countries and even across sources. And mostly because sources of data and data systems may have different specificities and different challenges or opportunities. For example, it's not the same as thinking incorporating gender or ethnicity or any other data in a census, which is released by every 10 years, than in a health survey or a household survey that is released yearly. There are resources and there are trainings and many other challenges that are needed, particularly related to gender and ethnicity. This multidimensional and contextual nature of these constructs is difficult, the operationalization and measuring of them. And you will see that we have also different ways that the nations or the member states in our countries are acknowledging ethnicity and gender identity. There is also, when we have data, there is also a fragmentation in how we approach this data disaggregation. And this is related also to aspects connected to data governance, provenance, and ethics that make difficult interoperability and also the use of data. So in this mission of advancing, you need to create more disaggregated data. I start like thinking how we advance, right? Because how we advance towards more towards the incorporation of gender and ethnicity in data information systems that we consider for health. It's not only about health, but also as other sources that could talk about social determinants of health. There is a balance between what is needed or desirable by the definitions we create and what is possible through the data representation that we have. I think what Theresa said at the very beginning, what we can operationalize or what we can collect sometimes is limited, and we need to acknowledge that. But as long as we are aware of those bias or those limitations, I think is the way we can construct better information. And how we move forward in this sense, and I think Matt was saying that they create also this importance of the data about the data. And I will say that within this metadata is important of acknowledging the processes of how you create the data. And so this is more or less what we are presenting as a workshop that we are going to hold at the end of May, but we call it data for equity. So how we can use the data for increasing equity, and also because data is so tied to the politics and the power relationships, the way we enable data or not is also a matter of equity. And we think that through the data cycle as an approach to understand that the data which is available or not has a political context. And what we can increase sometimes in terms of processes to incorporate more data may have not be directly linked to data itself. But data also could help saying, like, when we acknowledge that some data is missing, or we acknowledge that some evidence that we already have is partial or limited in understand, that could also impulse data. That's why we think this in terms of a cycle that never ends, and hopefully will help to increase or improve by itself. So for explaining this is the idea that there are legal frameworks, policies, and culture. I think Megan was acknowledging that are allowing or not, since the idea of defining or recognizing gender identity as part of the right to identity, or even the data policies, structures or frameworks to give sustainability to the data we collect. There is also this influencing how we conceptualize these constructs, and that also could determine how we create instruments for the data collection. And then there is a whole other process that is within the data, and this is mostly what we used to do at Salubal and many other projects here about, managing, maybe imputing data, maybe harmonizing data, making that data linked with other data to create some piece of information and then some evidence. And in that process also of managing this data, we also introduce many changes. Sometimes with collapse categories, we we do some tweaks to that data that sometimes lose the legitimacy or the provenance where the data was originated. So I think that when one of the conversations we start with Theresa at the very beginning was this worriness about how we keep the data as much as the data was created at the very beginning. So this workshop, or the idea we plan, is involving 9 countries that we selected because they have a different level of advancement in the incorporation of gender and ethnicity in different sources of data, either census or other sources relevant to health. And we try to combine, this will be a very social experiment, people with multiple expertise, because for this is not a problem only about information systems or data analysis, but mostly also on these other factors that are outside the data that are allowing the data to exist. So this has a lot to do with human rights, gender, cultural diversity, and multiple stakeholders in the sense that we are involving ministries of health and other UN organizations in the international development market. And this is more, I think, could serve as example, and maybe could serve also. I also piloting this so to see if that resonates with you, these kind of questions. And of course, I'm open to suggestions how to improve them. But the idea is trying to encourage through this question a discussion about the relevance and identify the opportunities and the different bottlenecks that we could have at different stages to create this data. And perhaps it serves also as a way of exemplifying this implementation of parent care principles. So related to the legal frameworks, I think it's important to acknowledge what actors, social processes, and national and international frameworks are important to acknowledge, are key to achieve regulations that enable the incorporation of gender and ethnicity data. Once we think about the conceptions or conceptualization of these terms, what are key elements that are needed to be considered and how they can also be operationalized, or how are these tensions between what has been defined and how we operationalize. In terms of the process of data collection instruments, is an important the design and the implementation. And it's important to acknowledge what the process are for designing this in a way that the data that we will collect is sensitive and responsive, not only to the definitions that were created, but also the needs of the population, as Amy was remarking. I think that's very important and very rich what she presented, and the social political context. And that's why also these things are also fluid in time. So many years ago, we may not have thought about gender identity as data that we needed, but since we are changing, in terms of evolving a society, we will need more vocabulary, more data related to that. And what processes and implementation of the data collection are key to ensuring consent and legitimacy, what Amy also was remarking in the context of and use of data. Related to the data processes, I think it's important also when we do this metadata record of all the data, it's important also, I think, to acknowledge or to register how we had or we implemented techniques or recommendations to overcome problems of access, frequency, and comparability, including standardization of data. We are focusing here on gender ethnicity, but this is transferable to any kind of data. What problems related to data access and integration, what problems of the quality, legitimacy, and relevance of data of gender and ethnicity exist in these systems for the analysis of health inequities, and how does governance, which is a very, very key point in terms of how we can connect data and how we can use data and share data of different information systems impacting their operability and integration. Finally, in the process of reporting, we are trying to dig in a little bit of how evidence generated acknowledges these limitations of potential misrepresentation and misapplication of the data used, and how what Amy also was remarking, how population of interest can legitimate and interpret this evidence, and how we can improve social participation for the incorporation and improvement of new data and evidence. This is very brief. It's more about processes. I hope you like this presentation, and here also this is my email in case you want to keep conversation after this. Thank you so much.
Thank you. Thank you. Well, now we'll open it up for questions for anyone in panel, audience online, whatever it is. Stop sharing. And anyone here? I actually have a question. I have a question for Anna and for Ran, actually, on the training you did, and actually Theresa, the training you did last year, which I believe a lot of people in the Department of Public Health attended. So if you could tell us a little bit more about that training, what was your experience with that training?
You were the leader, Ran.
Yeah, so I think the name, there's a lot of convergences. I think COVID happened. Oh, this is a little winding, but it'll make sense. COVID happened, and I think within public health, there was this urgency. It's like, yes, we need better infrastructure to have data. And at the same time, last year, the NIH also kind of understood this, and they started implementing the DMP requirements for grants, just because it's in their best interest to make sure that the people they fund generate reusable data, just to contribute to the overall research ecosystem. And so we put together this course as kind of a collaboration with World Fair, tying in the work that we're doing, as well as this new DMP requirement. And so I think this is very much borrowing from a lot of experiences between Theresa, who supplied the asynchronous material, so bringing in FAIR, and then Anna, bringing in kind of the more harmonization aspect. And then I taught some of the synchronous kind of practical ways of approaching FAIR, and really touching a little bit on, not focusing on the deep part so much. So I think it was trying to expose the community to FAIR. But to be honest, I think we were also very new to it. So it was a lot of learning for ourselves as well. But really excited to build on that in the future.
Great.
Just to add to that, one of the things that I found really exciting, and I could only attend remotely, obviously sitting in Australia, but it was so clear how engaged the students were with one another in terms of sharing. And I think that flags a really important part of this training, that not just the integration between the theory and the practice in the day-to-day, but finding ways to have the people who are seeking to use that training to be able to share their experiences in talk of trust, sharing doubts as well as successes within that context, to be able to all progressively move forward. And it's frustrating when it's a short period of time, but I think that's what helps to make it sustainable, is that they can still maintain the connection to it.
Yeah, and I think, just to piggyback a little, I think it is challenging, especially when you have a larger group of people, because it's the principles themselves and then the implementation. And it's very hard to teach an implementation that's generalizable. So I think we stuck with a very general approach to it.
I was going to add, because you first mentioned, and I also took a note, Ran, that, well, there's our best practices and FAIR principles are for implementing, but I think we need to think this as a gradient, as a level of fairness more than implementing something that is fair, right? Because the possibilities that we can achieve something in terms of fair or care are depending on, as I was saying, the systems, the maturity of the the information we handle. Megan, I think when you were talking, I thought so many statistical departments in Latin America saying the same things. You know, we need to digitalize first to start thinking then of fair, or maybe, or even, you know, these care problems are coming when you digitalize and you don't open data. So I think that it's a continuous, and it will depend. I think it's more a kind of utopic horizon that we would like to reach than something that we cut and paste and we implement as a can in each of the data. So the data management plans are kind of the outputs of this, but I think that we need to think it as these principles are more something that we continue work towards that.
It reminds me of like the ethical principles of IRBs, right? They're guiding principles. However, communities will say they don't think about community level ethical issues. They only think about individual level. So in all guiding principles, there's lots of, we should always be striving and aspirational to, rethink and, and improve upon, because there's always going to be, something we're not thinking.
But you just said, Anna reminded me of Galeano used to say that the utopia is not the place you want to get to. So you head towards fair principles, ways, like that, to help us guide where we want to go. Any other questions?
Can I make one kind of correction? Yeah. I think we also think about, I want your data cycle.
That's good, that's good.
And the ways that you were thinking about, it disaggregating in these important ways, around ethnicity and race and things like that. We need to be thinking about how our data is framed as deficit focused data instead of asset focused data. And one of the things I forgot to mention was that one of the reasons that we work so closely with our community partners, so the last thing they want is another report that stigmatizes their community or their neighborhood, and that's all they ever see. But it's also all the data that we have. And I think that very well-meaning public health programs have been like, this shows that there's need and we should invest there, but all it does is re-stigmatize the community. So, if we're dismantling and rethinking data systems, we should also be thinking about making sure that there is assets focused data in these data sets.
And this,
as well.
I
And
feel
not just 100 minus the,
no, definitely. And this is something I have been learning during this last year, because there is also an initiative at the same department where I work on social determinants, monitoring social determinants at the local level. But with all this perspective, of trying to engage people and that. So there are some examples, for example, in Chile, where they were able to, but they used it more for attending the social services and health services, but even I think it's a good resource for research. But they have connected social services with health services, the system of registries. And they have also this mapping display that they call Actives in Health, where, if a person or someone, who lives in that area finds that there is a cultural center or something that they found is positive for health, they can also introduce that data. With then a set of screening and the data people is curating that data, but they are also proposing what are things that they believe are good for their health so it's very interesting to see how different ideas are coming, into the same moment at different places. So.
Thank you.